One of the things about this law that I find fascinating is that there are certain things about the law that reasonable people can certainly disagree about the approach or how it's done. And there's certain things, especially some of the health delivery methods and payment methodologies designed to lower costs, that we know they worked, for instance, in pilot programs in San Antonio and in Miami and in Charlotte. But when you roll those programs out nationwide, you know, medical communities have cultures, and we know that when you roll them out nationwide, they might not work as well in Omaha and in Kansas City and in New York. So we know there's going to be some glitches going forward, but it's designed to, and we'll get to this, but designed to change the, basically the incentives involved, and move our system from one that gives incentives to do more procedures, whether they work or not, to one based on value that to basically give doctors as well as hospitals a bonus if they do procedures that actually work. But you know, I never get questions about those things. What I get are the three great myths I always say, the questions are, remember death panels?
Yeah.
You know, I always say, I volunteered to be on a death panel. I was so disappointed when I found out they made it up. You know, the other great myth, because I answer questions from all kinds, everything from everybody from Sprint Corporation to you know, Senator Johan's office to Senator Nelson's office. I mean, you know, for constituents, they all sort of get funneled through me. And if I can't answer them, I usually can find somebody in DC who knows the answer. Sometimes the answer is, well, we haven't gotten to that yet. But in any event, the three great myths are, one is the death panels, two is the allegation that when somebody turns 70, and then sometimes it's 76, but at some point, we're no longer going to give them care. I'm sorry, if you get cancer at 70, you don't get care anymore. Have you heard that one?
Yeah.
Oh, yeah. Yes, somebody called the other day with that, and I said, that's still going around? I said, yes, we're just going to take you out and leave you with a pack of wolves. You know. The other thing, by the way, just in case anybody's wondering, that's not true. The third one is that, did you know that right after the election, Medicare premiums are going up? They're going to be tripling. Did you know that? Well, and I don't know why, but it's always $247 a month. Right now, they're at $99. Last year, they were at $115. For several reasons, but partly because of this law, they went down from $115 a month to $99 last year. But you still get see these emails going around saying, you know, it's going up right after the election. It's going up to $247. I guess people figure $247 sounds like it's more right than $250. You know. So anyway, we're going to go through this pretty fast now. I always like to start real quickly with sort of what led to this law. It just didn't come out of, you know, the sky. The United States has by far the best, you know, medical system as far as what we do. We do way more procedures than any other country. We have the best medical schools. We train the best doctors and nurses. And people come from all over the world to come to our medical schools. We have the best technology, certainly the most expensive technology. We use a lot of it. And yet, consistently, we come out about 35th to 45th in almost every major measure of health system performance. This is sort of where we were headed. You know, fortunately or unfortunately. Thing is, the path we were on really was unsustainable, and it was really getting to the point where it was affecting our business. The Business Roundtable, which is an organization of the largest 1,000 biggest companies in the country, came out with a report in 2009 that said American companies that export, on average, spend about $2.38 per hour on healthcare costs. All our major trading partners average about 96 cents. And if you start getting into developing markets, it's around 15 cents. So there's just no way we could keep going on with this system and stay competitive as a nation. Health insurance premiums had doubled, more than doubled for large companies in the previous 10 years. And for small companies, they'd almost doubled. But actually, that was just as bad for small companies because they already pay between 18 and 25% more than large companies to insure their employees. 18% of our entire national output is going to healthcare. I mean, that's just stunning. There's only a handful of other countries that are even in double figures. Share of Americans under 65 who had job-based insurance going down, had gone down 9 years in a row. And perhaps most telling, this one really gets to me, is the last point. 62% of all personal bankruptcies are the result, or at least partly the result, of medical debt. Go next. Few people can afford medical services on their own. And believe me, looking at the bills I've been getting, I about, almost fainted a couple of times and then realized, oh, that was just the sticker price. That's not even the price the insurance company is paying. I get about a 65% discount off that sticker price, and then I just pay a portion of that. So, insurance is just indispensable. But there was a study that came out last year. They looked at about 15 years of hospital data. They found that 95% of the time that when people who are uninsured go in, they leave all or part of their bill behind. Well, who pays that? Even patients in the top 10% among the uninsured pay their bill only about half the time, have enough assets to pay their bill only about half the time. Who pays that? Go to the next one. Well, the answer is people with insurance. People with insurance pay it. On average, the average family policy includes about $1,000 to cover a year to cover the uninsured. And a significant portion is paid by taxpayers because a lot of these people show up at the emergency room. There's something called, what are called dish payments. Are you familiar with those? Disproportionate share payments. Well, these are payments made to hospitals for caring for people who don't or can't pay. And this keeps hospitals in business. But hospitals are very adept at moving the costs from people who can't pay to people who can, and that's people with insurance. And eventually, everybody uses the healthcare system, one way or the other. I'm pretty healthy. Frankly, I've been paying health insurance premiums for years and never, thought about it. I'm healthy. I hadn't used it. Well, boy, am I glad it happened. I've got it now. This is the Affordable Care Act at a glance. These are the goals. Improve the quality of care, lower the cost of care, increase access to that care, expand the base of people contributing to the system. Because as fewer and fewer people were contributing to the system, the burden on those people was going higher and higher, and that contributes significantly to the cost of health insurance. Fill gaps created by the old system. Now, how do we do this? And this is really at a glance. Everybody basically has to play a role. One of the principles behind this law is no more free riders. Okay? Large employers are required to contribute to the system either by providing health insurance to their employees or by paying an extra tax to the government to cover the cost of all those uninsured, or the care for the uninsured. Workers are required to contribute, all this is starting in 2014. 32 million newly insured should lower the average cost. Doctors and hospitals don't get a free pass. They're required to improve the quality of the care they provide, or they're going to start getting their payments nicked. And there's a whole slew of about half the law is new programs that try to lower the cost of health care. So these are the reforms that are already in place. These were the groups that Congress identified as being left behind. Early retirees and their spouses was a big one because a lot of times somebody, a couple has been married for 3-4 decades. The older one reaches 65, that person goes on Medicare, hey, no problem. What about that trailing spouse, which is usually a woman? There is almost no way that our private health insurance market today will insure you if you're over 55. Okay, they're just left out to luck. So the program was set up for them. All people with existing health conditions were shut out of the market. Small businesses and their employees have a very difficult time getting insurance. Young adults and then the children of all of these. You know how it is with young adults, they all think they're bulletproof. Okay, coverage for pre-existing conditions. Every state had a plan set up, was given a grant to help cover the costs. to set up what's called a pre-existing condition insurance plan for people who could not basically break into the private healthcare market. Now, these aren't cheap, they're not free, but they allow people to buy insurance at the same cost as if they did not have that pre-existing condition. The eligibility is you have to be uninsured for 6 months. They didn't want people who did have insurance dropping that and moving into these plans. You have to have the pre-existing condition, obviously, or have been denied insurance because of your health condition. And you have to be a U.S. citizen or a legal resident. Now, in our region, which is Kansas, Missouri, Nebraska, and Iowa, of those 4 states, the other 3 states all run their own program. Nebraska decided not to run its program, so the federal government operates the program here in Nebraska. These operate until 2014. 2014, they're no longer needed because insurance companies will be required to sell insurance to whoever applies and pays the premium. They won't be able to tell people, no, you've got diabetes, so we won't cover you. Or you once fell and injured your shoulder because you're an idiot, and now I'm not going to cover you anymore. You can always find, if you know somebody who could benefit by this, you can always call your state insurance department. They should be able to direct you. But this is the information on the federal program that's operating in Nebraska. Rates in Nebraska range from $132 a month to $568 a month, which is very reasonable. The $132 is for kids under 18. The $568 is for somebody who's over 55, and a very sort of generous plan. As of May 31st, a little over 73,000 people had signed up for these plans. A little under 300 had signed up in Nebraska. Okay, small businesses. There's 2 groups that really benefit disproportionately from this law. One is small businesses, the other is rural areas. But we'll get to rural areas because in rural areas it makes a tremendous investment in the rural health infrastructure, mainly community health centers. But also really puts a lot of money into recruiting a healthcare workforce for rural areas. But for small businesses, there's several really important benefits. One is a tax credit for small businesses that offer health insurance to their employees. Now, small businesses, even in 2014, if a business has fewer than 50 full-time equivalent employees, there's no requirement they do anything. But if a company has 25 or fewer employees, they might be eligible for a tax credit to help cover the cost of health insurance, if they choose to provide health insurance. The credit it's really for mom and pop companies, especially can be a help, especially to like family farmers who might employ a handful of people, and often for a very long time. I know farmers who have had the same people working for them for 10, 12 years. Well, if the employer decides, okay, I'm going to try to pay their insurance, they can get a tax credit of up to 35% of the cost of all their employee premiums. And that credit goes up to 50% in 2014. For even nonprofits, so if any of you work for nonprofit agencies, there's a mechanism by which nonprofit agencies can do this too. The credit is maximum of 25% for nonprofits, and it goes up to 35% in 2014. The maximum credit is for employers with 10 or fewer employees. So it's really aimed at sort of those mom and pop organizations. When I talk to business groups, I always say, there are things about this law that do expand parts of the social safety net, but that's not what this is for. This law does that because it's cost effective. At the same time, with small businesses, this is to help small businesses that perhaps could not afford health insurance to provide it and to compete with larger employers for it for workers. It's not to subsidize what you're already doing. The big complaint I always get is, well, I've got 40 employees. This isn't fair. Now my little competitors will get help. I'm like, yeah, but you were a little competitor one time too. We're trying to help them get bigger. Yeah, and that basically it's not a subsidy program for business. And most businesses frankly sort of understand that. Some of them grumble. Okay, next. Young adults. They can now stay covered on their parents' plan until they're 26. Anybody got a child who's on their parents' plan? It's amazing how many people. The thing about this provision is that it eliminates that classic situation where somebody graduated from high school, graduated from college, and what it was, congratulations, graduate, you lose your health insurance. Now they can stay on their plan until they're 26. They can be married, they can be living on their own, it doesn't matter. There is a small exception until 2014 in which if a child has a job that offers health insurance, then the parent's employer or the insurer can say, no, we don't want that child. We don't want that customer. The thing is that everybody expected that to be a big issue. That's why the exception was put in to sort of help the insurance market adjust, and it hasn't been an issue. I've only heard of one case where an insurer said, yeah, we don't want the customer. Almost always they take it, and the employers tend to like it because again, they wanted to keep the employer-based health insurance model because it helps them keep and attract good employees. So generally they've said, sure, we'll let the kids stay on the plan. That's no problem at all because it helps them keep their employees. About 18,000, sorry to say kids, but young adults in Nebraska have obtained health insurance on their parents' plan because of this. Filling the gaps again for kids. If a child is under 19, they can no longer be denied because of a health condition, denied health insurance. Funding for the Children's Health Insurance Program, that's an expansion of Medicaid that happened in the late 1990s. It was part of the whole welfare reform series of legislation. That is extended to 2015, and that's for kids who are from families modestly above the poverty level. And a really important part especially if you're involved in social services at all, is that foster kids will now be covered, starting in 2014, will be covered by Medicaid up till age 26. I mean, these are kids from really hard-scrabble backgrounds often, and this way they'll have one less thing to worry about until they're 26 to help them get started in life. Insurance, one of the big goals of this law is to make insurance more valuable, but also more comprehensive, to actually cover. Too many plans, you didn't find out that, it didn't cover that, and didn't we tell you it doesn't cover hospitalization? That kind of thing, isn't going to be done anymore. So what the law adopted was what's called the Patient's Bill of Rights. There's no more lifetime limits on benefits. And this affects a relatively small number of people, but for those people, it saves them from devastation. Because what happens is somebody will be paying, and this especially happens to people in their late 40s through 50s, they have paid into the system for years, through health insurance premiums. Then they come down with cancer, or they have a massive heart attack, or something happens that's incredibly expensive. So they've played by the rules, they've been part of the system, and they run up $500,000 in bills, and just as they're getting, 2/3 of the way through their regimen of treatment, they're told, I'm sorry, your insurance is over now. You only had $500,000 worth of coverage. Now, that sounds like a lot until you actually have that, have something happen. I started to tell, real quickly, there's a story about this. One woman called me from a small town in Kansas. She and her husband had done everything right. They had railroad retirement. She had a supplemental plan. She was 61 years old. She came down with non-Hodgkin's lymphoma. She ran up about $700,000 in medical bills. And basically, the insurance company cut her off. And she didn't know what she was going to do. They had done everything right. They had retiree insurance, they had supplemental, and it still didn't work for them. I was able to help her eventually get into the Kansas Preexisting Condition pool, but she had to stop her treatments for 6 months to become eligible. Well, that won't happen after 2014. Annual dollar limits are being phased out. No more dropping coverage based on an unintentional mistake. Now, fraud, they can still drop you, they can prosecute you, but an unintentional mistake will no longer count as a reason to kick you off your plan. And you get to see how insurers plan to spend any increase of more than 10%. It's a great website, healthcare.gov, healthcare.gov. You can go on that and type into the search engine rate review. And you can see there's a drop-down box of every state. You can just go to Nebraska and look at every insurance company since last August that has asked for an increase of more than 10%. Not only do you get a breakdown of how they're going to use the money, things like it'll say, let's say they were raising their price from $250 a month to $300 a month. Okay, that's a 20% increase. They've got to report this stuff. So they got to report it to the government. And most states do the analysis, but in other states, the federal government does the analysis. And you get a breakdown, so it says things like, okay, of that $50 increase, $14 is going to go to higher hospital charges. $12 is going to go to more doctor's fees. $6 to drug costs. $3.40 for croissants on Fridays. $2 for the third corporate jet, and $6 for additional profit. I'm joking about the jet and the croissants. They usually pack that under some other euphemism. But you get to see exactly how, but they have to give what kind of operating expense. And so it's very interesting to see how they break it down. But then you get an analysis by professional actuaries that says, yes, this is a reasonable rate increase because in that market, blah, blah, blah. It gives the reasons. Or it says, you used national data to justify this expense, and actually in your state, these expenses are much lower. And so you get a professional review of it, analyzing it, whether it's a valid increase or not. It's nothing like that has ever been done before. Go ahead. This is probably the most important single consumer benefit because it's sort of the foundation of all the rest. And I call it more bang for your buck. The insurance companies are now required, if you're in a large group, so large employer, generally more than 100 employees, sometimes it's more than 50, but a large group, they have to now spend at least 85 cents of every dollar of premium revenue on actual health services or what are called quality improvement programs, things like wellness programs, things like that. So basically it comes down to almost all of that on actual healthcare services. So you're getting value for your premium dollar. If you're in the small group market, which is small employers, or the individual market, it's 80 cents on the dollar. And one of the, I remember I was looking through doing some research and for presentation I was doing in Iowa, I found one company that was spending 40 cents on the dollar on actual health services. Now, is there anyone, I think they sold their plan to like 6,000, they had 6,000 customers in Iowa. Is there any one of those 6,000 customers, if they had known that they wouldn't have looked for a more cost-effective plan? Well, now the consumer doesn't have to do that. I mean, they probably should, but they don't have to do that because they're going to get rebates. And the first rebates started going out last month because this part of the law kicked in 2011. So the first rebates were going out in July for 2011. In Nebraska, rebates totaled just under $5 million. 3.7 million was in the individual market, and 1.1 was in the small group market. Here's the amounts that each company, if this is your insurance company, these are the amounts that these are the amounts that each company in Nebraska paid. Nebraska's got a reasonably competitive market. In Missouri, which has a very uncompetitive market, the rebates totaled more than $60 million. Go ahead. Which is really, when I talk to Missouri groups, I always say, this just shows you how you've been getting shafted for so many years, because Missouri has about 1.9% of the nation's population. The insurance companies made 5.5% of all the nation's rebates in Missouri. So yeah, it's ugly. But this law at least addresses that now. Medicare, one of the things I always laugh about is is the criticisms that, one, they say, the problem with this law is it doesn't do enough to cut costs. And then they say, one moment later, you know, this thing cuts $500 billion from Medicare. Okay, how do you reconcile those two things? Somehow they do it. There's like all good propaganda, there's a little bit of truth there. This law sets in motion a lot of payment changes that are designed to save money that have been estimated to save over 10 years. It's not all at once, but over 10 years to save between $400 billion and $550 billion. So that's a lot of money, but that's one of the goals of the law, is to reduce the cost of health care. As far as individuals, but that's involved with payment methodologies and the providers. It doesn't cut any benefits that Medicare beneficiaries receive. One of the big improvements is, and this went into effect last year, is free preventive services. With no copayment, no deductible, any cost sharing of any kind. And this applies not only to Medicare, but it also applies to private insurance policies. There are a few private insurance policies that are not covered by it, that are called grandfathered plans, but most plans, and we'll get to that in a moment. But with Medicare, the free preventive services is one of the big benefits, and the other big one that saves a tremendous amount of money for a lot of people is a discount on prescription drugs. And in 2012, this year, they get a 50% discount on prescription drugs once they hit what's called the donut hole coverage gap. In a nutshell, Medicare pays about, after a small deductible, Medicare covers 75% of drug costs up to about $2,900. At that point, the Medicare patient is just on his or her own. They have to pay all the cost for the next roughly $3,600. Now, for a well-off, comfortable senior, that's, okay, that's not that much. But for a senior on a fixed income, that can be devastating. So what do? They start either cutting their pills in half, or they don't get their pills at all. And then the problem that the drugs were supposed to address gets worse. They end up going to the hospital, which Medicare does pay for, at a much more expensive setting than just if they just kept taking their medication and kept the problem controlled. So while this costs some money, it's actually aimed at lowering overall costs by keeping people out of the emergency room. It's a 14% discount on generic drugs this year, a 50% discount on brand name drugs. Last year, those percentages go up every year. Last year, it was 50% on brand name and 7% on generic. In Nebraska, last year, a little over 24,000 seniors saved a little over $15 million. And through May of this year, almost 4,000 Nebraskans saved another $2.3 million. And for those people, that saving is going to continue for the rest of the year. This is the preventive care with no cross-sharing. As I said, Medicare beneficiaries became eligible for this at the beginning of 2011. For private plans, this applies to all plans that began or renewed after September of 2010. So almost all plans now, unless they were grandfathered, cover these. Remember the promise was made, if you like your health care coverage, you don't have to change it? Well, those plans are called grandfathered under the previous laws. So they don't have to cover this. But you know what's happening? For competitive reasons, almost all plans are giving up their grandfathered status. And this happened to me, just a quick story. You'd think I'd know this. I got my son was starting college this year. He was a high school senior last year, and my wife said, okay, hey, let's get him, he hasn't been a doctor in a long time. We need to get him checked out before he leaves. Okay, so he goes to the doctor, he gets his checkup. I get this bill in the mail, and I'm like, this is supposed to be free. I don't have to pay this copayment. So I call him up. Turns out I just didn't read my plan closely enough. It's a grandfathered plan. But they said, but we're giving up our grandfathered status on January 1st. So if I had just waited to have that appointment in January, I wouldn't have had to pay that $35 copayment. Anyway, these services include mammograms, colonoscopies, and again, this is making insurance more valuable. Vaccinations, helping quit tobacco, a whole slew of screenings. I've got some handouts up here that include a 3-page list of all the things that are covered. There's also, effective August 1st, a whole slew of women's health care preventive services takes effect. Everything from breastfeeding supplies to HPV testing, and that's regardless of pap smear results, to domestic violence counseling. Anyway, there's additional women's health care things that take effect, and it's for plans that begin or renew after August 1st. So for most people, that's January 1st is when those provisions will kick in. But for some people, it might kick in October 1st or September 1st, whenever it renews now. Significant number of women's health issues have been added to the list of preventive care that's now free without any copayment. Fighting fraud. This law boosts investigations by $350 million over 7 years. In fiscal year 2009, they went up about recoveries went up about 29%. This is an issue close to my heart because for about 2 years back in the mid-1990s, I did nothing but investigate Medicaid fraud. And I'll tell you just a real quick story. My favorite story was the 2 ambulance companies in a very small rural county that were going around to housing projects and giving people cigarettes in exchange for taking rides in the ambulance so they could bill Medicaid. And think about that. That's so wrong on so many levels. Anyway, in 2010 and again in 2011, fraud recoveries topped $4 billion in each of those years. Go ahead. As I said about rural areas, about the benefits to rural areas in this law, one of the biggest is $11 billion that was set aside over 6 years, to invest in community health centers. We know if we're going to have a lot more people with insurance, we're going to have a lot more people who are trained to take care of them. We don't want bottlenecks in the system. So $11 billion is set aside for building and expanding community health centers, and they're designed to double the number of people, the capacity to treat people from about 19 million now to about 40 million in 2016. Go ahead. These are the grants that have been given to Nebraska health centers so far. $15.3 million has come through the Affordable Care Act, and $6.4 million was part of the 2009 Recovery Act. Just last June, One World Community Centers in Omaha got $500,000, and Charles Drew Center in Omaha got $477,000. In May, East Central District Health Department in Columbus got a $5 million grant to expand their health center. If we have these new clinics, we've got to have people to staff them. So $1.5 billion was added to the National Health Service Corps, which is a program that started in the early 1970s. It basically allows medical students, dental students, nurse practitioner students, all these professionals to pay off their medical school debt or their college debt, whatever debt they have, through service in an underserved area. So $1.5 billion has been added to that. For just last year, this is last fiscal year, so that's the year that ended September 2011. It's the first year this was in effect. 49 primary care providers were placed in Nebraska. 471 were placed in the 4-state region. The goal is to train 16,000 new ones by 2016. And in just the first 2 years, they placed more than 5,000 people throughout the country. This is one of the health delivery systems. When I talk to doctors groups and hospital groups, medical provider groups, we go into excruciating, painful detail in how these things work. But this is just for a summary. What the systems are is, and this kicks in for hospitals on October 1st. Hospitals are doing handsprings to get ready for this because we're changing the incentives. No longer will hospitals be able to just bill for whatever they do, whether it works or not. We're moving to a system called value-based purchasing. What this is they take They reduce all hospital payments. This is a simplified version of it, but they take 1% of their payments from Medicare. That's about $850 million. They take it away from all of them. Then hospitals that are in the top half of the performance criteria, so if they do better than the national average, they're going to get their money back. And if they do well enough above the national average, they get all that money is paid out in bonuses. Those hospitals that do below average, they don't get their money back. That's how it starts. And what this is it's borrowing a lesson from manufacturing, frankly, the continuous quality improvement. As hospitals compete to try to get into that top half, that national average is going to start moving up. And who's the beneficiaries of this? It's patients. Right now, 1 out of every 7 Medicare patients that goes in the hospital, 1 out of every 7 has something go wrong. That's just unacceptable. Other countries don't have a system like that. And what this is to say, look, we've tried all kinds of things. Winston Churchill said, you can count on Americans to always do the right thing after they've tried everything else. Well, this is after everything else. We tried. Now we're hitting them in the wallet where it counts. And already hospitals are streamlining operations, becoming much more efficient. A similar system, although more complex, will go into effect for doctors starting in January 2015. Next. Okay, what's ahead? Okay. Beginning in 2014, you've probably heard about these health insurance exchanges. Sounds kind of ominous. What it is just a store. I call it I say it's sort of like a Travelocity or Expedia, except for health insurance. And Sandy Prager, the health insurance commissioner in Kansas, always tells me, don't say that. They're much more complicated than that. And behind the scenes, they are very complex. There's all kinds of things that people running an exchange have to do. But from a consumer standpoint, I think it's very fair to compare it to Travelocity. The phrase in the law is that there shall be no wrong door. No matter how somebody comes to find an insurance policy, they'll be led to the exchanges to say, look, here's a list of every insurance company that's offering health insurance. And we'll get to some of the ways that we make it more affordable in a moment. If you want to get an example of a very simple exchange, how it might work, you go to healthcare.gov and there's a big blue box on it. And you click on it and it says, find your insurance options. And you click on it, basically you just put in your zip code. Every zip code in the United States is covered. And you put in what you're looking for. And what I do, I use, you always use yourself as an example. Oh, okay, so I live in Midtown, Kansas City. So I put in my zip code, 64110. And then I have the mythical 3-person family, a woman 40, a man 39, and a 10-year-old kid. Okay, non-smokers. Okay, what are my options? How many policies do you think came up? This is the small, just for my family. This isn't a group policy. This is just, how many? 10? Anybody else? 2. 25. I would have thought 20 to 30, just because, populated area and everything, be some competition. We're 95. Oh my God. Who would have known that? And you get a breakdown of, how much it costs. You can play with it and you can say, I don't want to pay more than $600 a month. I don't want, and then it's down to 58 plans, or whatever. And then you say, I don't want a deductible of more than $2,500. And it goes, shoom, now it's down to 43. And you can keep adding different parameters. I want to make sure it covers maternity benefits. I want to make sure it covers prescription drugs. I want to, and it'll keep narrowing it down. And then it gives 2 great little consumer tips. One of them is, well, this looks like a great price and, great plan. And it says 84% of the people were charged more. Whoa. Or it'll say, 9% of the people were charged more. So it gives you some idea of whether this is sort of a bona fide offer. The other little tip is, let's say it's $500 a month. And it says, but 68% of the people were denied. Or 8% of the people were denied. It gives you, information about it. Well, that's how a simple exchange might work. And On healthcare.gov, finally, it has a link to the actual insurance company website and for information about where you might be able to have a, to find an insurance policy. Now, that's a very simple kind of exchange, but it gives you an example of how it might work. Go ahead. I just want to point out, Nebraska has received about a little over $6.5 million to plan for their exchange. States have to notify the federal government by November 16th, whether they're going to run their own exchange or whether the federal government will run the exchange. It looks like in Nebraska the federal government will run the exchange at this point. We think it's good that for states to do it because medical communities have cultures and states can arrange their own exchange to work. Okay, but if they don't, the federal government will run it for people. It'll be a little bit generic because obviously, they won't. It won't be tailored completely to the state like a state exchange could be, but it'll still, function for people to do this. Go to the next one. Okay, just a couple more points I want to make real quick. This is a real key part that people don't realize, I think. This is what I call, it puts affordable in the Affordable Care Act. And this is, in 2014, people will be required to carry health insurance, through their employer, through, if they're low income enough, through Medicaid, if through private insurance somehow. They'll be required to contribute to the system. As I say, the basic premise of this law is no more free riders. And workers if you've got health benefits, if you have job-based insurance, this doesn't apply to you. But if you have to buy insurance in the private market, and you have income of up to 400% of the poverty level, you'll get a subsidy. Basically, it'll be paid directly from the U.S. Treasury to the insurance company you choose. You'll just pay the difference between the price of that policy and your subsidy. Now, 400% of the poverty level gets well into the middle class. For one person, right now, it'd be a little under $45,000 a year. For 4 people, it'd be up to $92,200. Now, the subsidies shrink as your income goes up. So if you were last estimates I saw, if you were a family of 4 and had an income of about $78,000 a year, you'd probably get a subsidy of about $3,500. If you were a family of 4 and you had income of about $34,000 a year, that's pretty basic, you would get a subsidy of about $9,900. So if you chose a plan that cost $10,500, you would just pay that $50 a month or $600 a year, the difference between that $9,900 and that $10,500. In addition, I hope you're seeing how the different parts of the law work together. In addition, they're getting insurance customers get a much better value for the insurance they're buying as an incentive, to make it actually worthwhile. Okay, next one. For people with incomes too low to buy health insurance, Medicaid is supposed to expand to 133% of the poverty level, and there's the annual limits. If you work, none of this is anybody getting rich. If you work full-time at minimum wage the whole year, you do not qualify for Medicaid, even under the expansion. Okay, one person, it's a little under $15,000. For a family of 4, it's about $30,600. They would be covered by Medicaid. As I said before, this isn't designed, it does expand the social safety net, but what it's designed to do is save money. Keep these people, we're already paying for this group of people. We're just paying for them in the most expensive possible way at emergency rooms. Well, this is to get them into some kind of consistent care that will control a lot of these chronic conditions that low-income people often have and keep them out of the emergency room. So I just want to make a plug for the healthcare.gov site. This is it. It's that big blue box in the corner, or in the upper left-hand side. Explore your coverage options. That's what I was talking about. And you can find out all kinds of stuff. Details about the law. You can even see and this is a highly underrated part of the Affordable Care Act, is if you read the actual legislation, it's a very effective cure for insomnia. So So, but you can go to this site under, it says understand the law is one of the links at the top. Just click on that, and one of the drop-down things is read the actual law. So anyway, this is my last, I always like to close with a closing thought. You know, none of this is going to be easy when you're changing a $2.6 trillion system, trying to change the incentives. None of it's going to be simple. There's going to be lots of people who benefit from the current system who are going to badmouth it and not like it. There are other people who are just, you know, not sure. And, you know, but some people will definitely benefit by it under this law. And a lot of that small businesses in rural areas. Well, I think the biggest misconception is that somehow the government is taking over healthcare. Actually, there's no change. We still use private insurers. We use private healthcare providers. We use you know, private settings. We make our own decisions. Decisions are made by your doctor and you. The government really is only setting up a structure to help you buy health insurance. The biggest misconceptions are just, you know, certain interest groups who are benefiting by the current fairly dysfunctional system, you know, aren't going to enjoy moving to a system that's more efficient and that costs less because they're finding the current system very lucrative. So, you know, a lot of them say things that, you know, basically just aren't true. I spend a lot of time answering questions about, for instance, that Medicare costs are going up. Well, actually, Medicare premiums went down $15 a month this year, partly because of the Affordable Care Act. People say, oh, they just make up things like, oh, when you hit age 76, you'll no longer be allowed to have any health care. You'll just be taken out to the forest and left with wolves or something. That's not going to happen. Nothing changes. In fact, the Medicare benefits become a lot better because we've found that it's less expensive to keep people healthy than to be constantly treating illness. Well, I encourage people to be informed because the more people have actual facts, the better off they'll be. They'll be able to understand what the law does, how the parts fit together, how they save money, and reduce overall costs. In addition, you know, starting in 2014, you know, a lot of critics have bemoaned the fact that the law requires you either to carry health insurance or to pay an extra tax. Well, that's because this law, one of the themes is no more free riders. You won't be able to go without health insurance and then show up at an emergency room and then walk away from your bills and stick your bills onto everybody who has insurance. When somebody goes to the emergency room, somebody has to pay for that. Right now, that's people with insurance. We want to change that to a system where everybody is carrying the load, and that should reduce the cost to everybody. Well, to be more informed, one of the best websites I know of is a website called healthcare.gov or healthcare.gov. It has more than 3 billion pages attached to it, so you can spend hours if you wanted to. But you can just simply click on some of the links to be taken to pages that show, you know, preventive care that's now free with no co-payment or no deductible, because we want to keep you healthy. It's less expensive to keep people healthy than to constantly treat illness. If you want to find out about where you can find insurance coverage, there's a link for that. If you want to find what your state has received, how many grants it's received to expand its healthcare clinics and its healthcare system, you can click on links that'll take you to a map of the United States, and you can just click on your state. There's just dozens of pieces of information on that healthcare.gov website. In addition, there's certain foundation websites that have very good information. The Kaiser Family Foundation, and as well as, for instance, locally, the Healthcare Foundation of Greater Kansas City. Also a website called reformreality.org, so reformreality.org, that explains a lot of the portions. And you can also check with your aging centers, the area agencies on aging, including the aging partners here in Lincoln, are very informed and have a lot of good information about what's available and what the law does and how you can benefit from it.